Welcome, Dr. Melissa Pessin. Dr. Pessin is the chair of laboratory medicine at Memorial Sloan Kettering Cancer Center in New York, the epicenter, of course, of global COVID-19 pandemic. Welcome, Dr. Pessin.
Thank you.
Firstly, if you could tell us surgeons a little bit about your background and what you do before we go on to the actual questions, it'll help put everything in context.
Well, at Memorial Sloan Kettering, it's a little bit different than many sites where the Department of Laboratory Medicine is totally separate from the Department of Anatomic Pathology. So what I'm in charge of as chair is running all of the diagnostic clinical tests that have to do with blood and body fluids, infectious disease testing, blood banking, and cell therapy product processing and administration for all of the patients throughout the whole MSK system.
With that background, which is helpful to our viewers and listeners, how sensitive and specific is serology testing for COVID-19?
Oh, that's like the multi-million-dollar question. So it depends very much on exactly what assay or what kind of laboratory test you are using to do that testing. There were over 70 different serology tests that registered with the FDA, and they all have different test characteristics. So it's very important to actually know what test you're dealing with. In most cases, there are tests that can be as much, I don't think anything is 100%, but there are tests that their data is stating they're as much as 99% specific. The sensitivity for this is very interesting because it really depends on how far out somebody is from their COVID-19. Very close to their COVID-19, their symptoms being gone, less than 5 days. Not a lot of people have antibodies. As you get further out to 14 to 21 days, almost 100% of people have their IgG. But I think there's a lot of, that's in fact what the serology testing needs to determine. People have different time courses of whether they develop IgM and then IgA also, depending on how severe in part at least, how severe their illness was. There are reports of people who were culture, positive for COVID-19 and really don't make much of an antibody response, and then others who make a very dramatic antibody response.
Could you let us know a little bit about the availability of these tests, length of time to perform them, kind of the mechanics, cost, anything that would be useful for those of us in practice thinking about operating on patients?
Okay, so there are multiple different kinds of tests, and they take different amounts of time to run. You've heard of some of the more rapid tests. Those are called lateral flow assays. They look a lot like a pregnancy test, the stick, and you put the sample on and out comes the result in, usually something under 15, 20 minutes. Those tests are the ones that have had the most issues with sensitivity and specificity to date. And those are a lot of the ones that flooded the market early. While they're fast, fast doesn't always get you the best result. That's one set. The other set you may hear a lot about are called an ELISA test. And those are tests that are done often in a 96 well plate, you put samples in and you run. Those take several hours to run and are a batch. So you run a plate with lots of samples in it and get a result. Can take anywhere from, 4 to 12 hours. Turnaround times on those can be, a day because they don't run them all the time. The newest tests that are just coming out are more traditional immunoassay tests. Those are coming out from Abbott, from Beckman, Ortho, I believe too, Roche. And those are run on our standard big immunoassay platform. So those can be run in much more real time. So we've just brought that up, the Abbott assay at our place, and it probably takes about 45 minutes to run, and you can run lots of those. So we can run, maybe 200 an hour if we were running full out. But the restriction with all of these is the availability of the assays. So if your institution, and we're still having trouble, that we're just starting to get those tests online, hopefully the restrictions of assays are going to be less with this than everybody heard about with the viral testing, where we were restricted in terms of, all sorts of steps, from the swabs to the to the reagents themselves for that. Obviously we have lots of vacutainers, so we can draw blood pretty easily. So that won't be a shortage. And it looks like the bigger commercial producers like Abbott and Ortho are making plenty of tests. So that doesn't seem like that's going to be as big an issue.
It would seem to me that serology could be used for two separate facets, perhaps more, but diagnosis and then proof of immunity. And can you talk a little bit about how COVID-19 serology tests fit in both the diagnostic and the proof of immunity phases?
And the antibody tests do not and should not be used for a diagnosis of an acute COVID-19 illness. The antibodies do not come up until days, sometimes weeks after someone has an illness. So it's really not good for and should not be used for any acute diagnosis of someone you think is currently sick with COVID-19, with SARS-CoV-2. What it is good for, though, is to see if someone has an exposure. So if you're looking to see if somebody had COVID before we had testing or wasn't tested, and then they have antibodies, that's what this is going to be good for in terms of saying, yes, you in fact were exposed, and that illness you had in early March was a COVID infection, so you've had the infection. Whether it's protective, whether those antibodies are protective, is nobody knows yet. So it tells you you've had an infection, but that's about it. So it's going to be very good for use in epidemiological studies, use in prevalence studies, makes people comfortable that that illness they had, again, that they weren't tested for because of the limitation to the testing that happened at the beginning, particularly at least in New York, was in fact the COVID that they thought it was. Or for some other people who were hoping that that illness they had in January or February was COVID, it'll tell you, no, I'm sorry, you actually really didn't have COVID. But it's very important that people keep up their use of PPE and social distancing, because there's even some evidence that some people who make antibodies still have detectable virus. Okay, not that it necessarily is infective, nobody knows that. So that's really kind of where we are in the antibody testing right now.
Given what you just said, is it reasonable to use the test to help decide if people can return to work? There's a lot of stories about that in the lay press, kind of your passport to work and all of this information. Should we rely on it?
I think it's too early. I think that nobody knows if these antibodies are protective. So to use that as a return to work is a question. I think the question is still out a little bit on whether someone can be reinfected with the SARS-CoV-2. Most people are thinking not, and not acutely. We haven't seen that many people. There were some early work from China that showed that there were some people that they thought might have been reinfected, but the question is they thought maybe on reinspection that could have been reactivation. So I think a lot of that has gone away. So I think it's too early to say whether those antibodies are protective. So that shouldn't be used as the reason to allow someone back to work. And one has to be very cautious if you want to use it as a reason to allow somebody to be more frontline with COVID positive patients at this point.
Interesting, because along those lines, again, there's a huge amount of information in the press that we really need more widespread testing to open the economy. And although this isn't inpatient care by somebody in charge of the lab, but what are your opinions of it?
I don't think we know enough about what those antibodies mean to use those as the basis. Again, it's going to tell us how many people were exposed. And presumably, if we're trying to get to a herd immunity model like Sweden does, it's going to give us those kind of numbers. If we ever got to a point where we were at 60 or 70%, of exposure, I think we could be thinking that's more where we're at. Even the New York numbers on their preliminary study that was done with the New York State Department of Health, New York City was in the 20s, low 20%. I think most people saw that data. So not anywhere near that. It'll be interesting to see once that prevalence study is expanded, whether that holds up or what we see with that.
Thank you. And I suspect I might know what you're going to say for the next one, given what you said about the serology, but PPE. So there's a few scenarios. One would be the patient who's got antibodies. The second, the healthcare provider with antibodies. I mean, where do we stand with the use of PPE in those settings? Does the healthcare provider need to use, if he or she has antibodies already? Does the patient need to use, well, just the mask in that case, if the patient's got antibodies?
I think that the healthcare providers at this point still should use PPE. Again, it's a question. Nobody knows if the antibodies people make are protective. The tests that need to come out to determine that are called neutralizing antibody studies. Those are very, very difficult to do, and there are a few places that can do them, but it's not something that's widespread. Unless you know you have neutralizing antibodies, you don't know that you're protected. So I would encourage all of the healthcare providers to continue wearing their PPE. For the patients, if people want to be sure that someone doesn't have detectable virus, you'd have to go back and do, again, the viral test to ensure at this time. I think as we get more information and people have done the studies to look at the viral secretion versus the antibody testing, we may know better. There might be a point where we can say there's no, at 21 or 30 days or 40 days post, your infection, the odds of someone still, being able to transmit virus are very small. But I think we're still way too early in the timeline of this infection to be able to absolutely, without a doubt, know that. So for the time being, I would still keep patients as well in the mask.
I greatly appreciate your expertise, your time, and sharing your tremendous insights and reflections with us today. I wish you and your loved ones sustained health and safety, and hope that the situation in New York continues to quiet down, and that you're able to get all of this pandemic quickly behind you. Thanks again.
Thank you very much. I wish your family the best as well. Thank you.